Yeah, I think we can get started. So thanks everyone for joining us. How many of you are auditing? Can you raise your hand if you're auditing? Oh, that's just a couple of you. Okay, so we have a great lineup of speakers for you this semester. So this course is really, the goal of it is to connect you with real world aspects of healthcare AI. So we have speakers from the industry and from UCSF who are working on real world development and deployment and regulation of models in the healthcare AI space. And we are very excited to have our first speaker to be Dr. Julian Hong from UCSF to talk about the Smart Cancer Center. So Julian is an associate professor and medical director of radiation oncology informatics in the Department of Radiation Oncology and the Baker Computational Health Science Institute at UCSF. He's also a core faculty member at CPH, Computational Precision Health Department, that hosts this lecture series. His research focuses on the development, implementation, and evaluation of computational tools in the clinic to provide personalized and precision cancer care for patients. And he led one of the first randomized control studies of clinical machine learning, which I hope you'll touch on today.
We'll talk about it.
That's really a very exciting thing. People usually evaluate models on data sets, but they don't really test them prospectively within healthcare systems. So we might hear a little bit about that today. So this model developed electronic health record-based algorithms that accurately direct care to reduce emergency visit and hospitalization during radiotherapy. And his work has been recognized with the Radiation Oncology Institute Publication Award, BioIT Award, Innovative Practices Award, and the Symposium on AI for Learning Health Systems, New England Journal of Medicine Travel Award. So thanks so much, Julian, for joining us today, and good day right here.
All right. Well, thanks for the generous introduction, and thanks for coming in, and thanks for everybody who's logged in on Zoom. So, and thanks for having me be like the first speaker for the seminar. I think it's just like a great program. So, very casual. So, if you guys have like questions and stuff, we'll try to keep an eye on Zoom. But I'm always happy to take slight detours as we go. And then I think, well, we'll see how the owl's picking up audio from people who are asking questions, but I'm also happy to repeat questions so everybody on Zoom can hear them too. All right, with that said, I've got slides, but again, semi-informal. Let's see. Did I hit the right thing? There we go.
People are seeing slides already.
Yeah. All right, I think we're up. All right, okay, I think we're good on Zoom World. Okay, all right, so I'm going to be talking a little bit about trying to bring data to cancer care. We of course, evidence-based medicine very much apply clinical data in our daily decision making as clinicians in the cancer center, but really trying to think about newer ways that we can actively and proactively use computational approaches to improve care for our patients. These are my disclosures. All right, so I've got a bunch of like XKCD comics like littered through the slides too. So you'll see this one plenty of times, so like you don't have to read it all at once now. But this is our roadmap for today. I'll give you a little bit of an introduction to myself and to what I do. We'll talk a little bit about electronic health records for those who are not as familiar about them. We'll talk a little bit about kind of the thought process of translating computational tools into clinical settings. I'll talk a little bit about SHIELD RT, which was our randomized control trial. And then we'll talk about some future directions, both as far as like kind of long-term surveillance of algorithms and some of the sort of newish things that we're working on in my group. All right, so I'm clinically I'm a radiation oncologist, and I specialize in GU cancers, primarily prostate cancer and bladder cancer. Folks don't, as frequently hear about radiation oncology, even like folks who are going to med school, they hide us in the basement in a lot of departments because we need like the extra shielding for radiation machines. Though that said, our department at Mission Bay is actually on the ground floor, which is kind of nice. We have windows. But about half of patients with cancer will ultimately receive radiation as part of their treatment. And it's a fundamental part of curing a number of different cancers. So prostate cancer certainly being one example of that, where we typically consider radiation and surgery as equivalent options for patients as far as curing localized prostate cancers. And then we also frequently use it in combination with other types of treatments. So cancer is a very multidisciplinary sport. And so we combine it frequently with surgery or chemotherapy. We have multidisciplinary tumor boards where we try to put comprehensive plans together for patients. So just a little bit about kind of my clinical world, because that way it'll help you sort of think about some of the problems that we work on. Patients who come in for radiation, sort of the most frequent type of radiation they get is something we call external beam radiation. And the way I describe that to patients is basically high energy X-rays that we shoot at tumors from the outside. So think about like Death Star type situation. So, and so patients come in, they get a CT scan done. We use that to create a computer model of their body. And then my job as a radiation oncologist is to trace out where we want radiation to go, which is essentially where the cancer is or could be, and then trace out where we don't want radiation to go. So that's normal organs. So this is actually an example of a prostate radiation plan. And let's see if this cursor will work. This right here is the prostate. You can see I'm on this side view right here too. And then the idea is to design a radiation plan that is focused where the radiation hits the prostate, but avoids important normal organs like the bladder and the rectum and the hips. And so that's kind of what I do on kind of a routine doctoring basis. It is a very like technical, computer heavy field in general. And then patients come in to do their radiation treatment that we programmed in the computer. And patients can come in anywhere between like one treatment up to like 9 weeks of radiation. And I see my patients every week. And we talk about how they're doing, manage any of their symptoms and side effects. So I see them for a very sort of intense period in their lives while they're undergoing a specific treatment. And then from there, I'll actually see patients in long-term follow-up. I often joke with them that they're stuck with me forever as we, are doing surveillance or whatever to make sure that they're doing okay. And so that's kind of like my clinical world. And then I wear multiple hats. So I also have some computational background. My undergrad degree is in biomedical computation, and I have a master's in bioengineering, both of those from an institution that I won't mention on this campus. And then I'm board certified in a specialty called clinical informatics, which I think has been a bit of an emerging a clinical specialty that folks will add on to their clinical training. These days, folks will actually do fellowships in clinical informatics to gain some extra expertise. We'll talk a little bit about electronic health records, sort of relevant. They have a certification program for Epic, which is one of the major electronic health record vendors. And then I direct radiation oncology informatics and report up to UCSF Health on the operational side. So that's kind of me in a nutshell. Most of my time, I'd say calendar wise, is spent leading our research program where we focus on stuff that I'll talk to you guys about today. All right, so Ahmed asked me to give a little bit of an intro to EHRs today. So for those of you who aren't as familiar, I decided to like Google image search electronic health records just to see what would come up, mostly because I was looking for good screenshots for you guys. And then I was like, well, a lot of these like images aren't like particularly informative. So I resorted to borrowing some slides from one of my friends, Annabelle Disha, who leads one of the EHR based courses over at UCSF. So I'm gonna get this Zoom thing out of you guys' way. Let's see if I can move that for people who are here in real life. All right, that wasn't as easy as I thought. I think we can work with it, right? Okay, so in the electronic health record system, there are a number of things that we use the EHR for. We often think of it as being a source of information for clinical care, but there are actually a lot of other things that it's responsible for. And to be totally honest, a lot of the design decisions around the electronic health record are actually based around other uses, particularly billing. So oftentimes, you'll hear about physicians having, challenges with the electronic health record because of some of the design functionality. And in each EHR system is built around like sort of different elements, but all of them do act as a primary source of information for physicians as we're taking care of people. I'll say we used paper charts when I was an intern at the hospital I was working at. And that was crazy because, there's one binder, there's only one place, only one person can use the binder at a time. You're like handwriting stuff in. And so EHR really transformed care when it became more widely adopted. This is a screenshot that I did find online, showing something that looks similar to sort of what our schedules look like at UCSF. And so usually when I'm seeing someone in the clinic, I get, I have a schedule of different patients. I can double click the patient, open up their chart and navigate and see things. And then there's tons of information inside the chart. We have clinical documentation, so clinical notes, where there's unstructured information. The vast majority of information content inside the electronic health record actually lives in unstructured notes compared to the structured information that I had on the last slide. So that's an important consideration. And then there are just a lot of, like, if you look at this, like, there are just a lot of places to click and shift your attention and multitask too. So, but this is kind of what the health record looks like. And it sort of comprehensively covers all of the healthcare information for a patient. And that's kind of how we access it. All right, so we're going to get into the sort of AI machine learning part of things. And so as I was saying, the electronic health record is one piece of the puzzle. We have a number of different sources that we sort of manage in healthcare. In the radiation oncology clinic, for instance, we have actually a second EHR that I didn't show you slides on that manages all of our kind of radiation specific information. We also have a separate imaging system that collects like all of like the digitized like imaging data. And then there's a ton of stuff too that probably like least accessible lives in scanned PDFs, which is a very challenging thing to go through. I have some days where I have to flip through like a 500-page PDF. It's not the easiest thing in the world. So those are tough days. So we collect huge amounts of the data, and I sort of think of it as like raw data in the healthcare system. But what we really want to do, right, when physicians are working in the clinic is we're trying to like get some meaningful information out of navigating that data. And then we want to translate that information content that we pulled out into some kind of useful knowledge. And then, of course, what we're really trying to do at the end of the day is to take care of our patients. And so really, trying to convert that into clinical impact. And then the whole process itself is cyclical. And I think this is an important point to make, which is that, the process, the healthcare operation, the process of taking care of patients generates the data. And there are a lot of nuances in how we create data in the clinic. The data, as many of you guys know, this is true in a number of different fields, it can be messy. So the data can be messy. There are a lot of limitations that are imposed based on the domain of where they're being extracted from or being created from. And so this cyclical process is really how I think about like data cycling through the health system. I thought I'd summarize kind of briefly the type of work that we do in my group. So I sort of lump them into kind of three kind of major domains. We apply different types of analytical techniques to clinical informatics data. I sort of broaden this to digital health. So you guys will hear about some machine learning AI work that we do in our group. I won't talk as much about natural language processing, but we do a fair amount of work on NLP, specifically geared towards information content and understanding biases and limitations in that textual data that I was presenting to you guys earlier. And then we have a growing portfolio on wearable devices. And then the idea is to take things that we build out in my lab into clinical practice and to test them to see if they actually work. So many, we'll talk about this in a bit, but so many things, don't make it to patient care. And so it's really fundamental to get to that point so that we can test it. And then on top of showing that it can work, in sort of its like analytical process and make good predictions, really see that if we can tie it to an action in the clinic to improve the care of our patients and improve patient outcomes, or actually improve the physician experience, which is also part of our portfolio. So I'll talk a little bit about some randomized trials today. And then, of course, the end game, as I mentioned, is to help patients and help our staff in the clinic. So how do we get there? So this is kind of like a roadmap, as far as like kind of how we think about designing analytical tools in my group. And so we start off with like kind of the compute process. And I think the thing that I wanted to highlight here is that, we look to develop analytical tools that are, that are accurate. But over, I'd say the past like 5 to 10 years, there's been a growing appreciation for the intrinsic biases that exist within the data sets that we have, whether that is bias because of processes that we have in the system. So for instance, like when patients get labs, like, patients usually get labs in the morning, and then it's informative if patients are getting labs at other times of the day. And so it's important to keep those workflow things in mind. And then Ziad's paper that I have here is now, I think, also another classic, discussing racial biases in a commercial algorithm that were linked to the way that healthcare status was essentially quantified. So a number of like kind of important considerations in our group. We were kind of focused on cancer. So the first of these here is about differences and discrepancies as far as mental health diagnoses in our experience in the electronic health record, and then a little bit about our experience in helping patients get access to patient portals, which is kind of the main way that patients access their electronic health record too. So I highlight, for those of you who are interested, a couple of nice guidelines that kind of help offset like and think about the considerations in making accurate and fair algorithms, which are nice to have as a reference. But then once you've kind of gotten through that process, and you're trying to figure out, well, hey, I've got this model, I think it'll work, or I think it, it functionally can help us in the clinic. What do we do next? And this is a nice study that came out of Google DeepMind, where they ran a model to predict acute kidney injury. So basically when people are having short-term kidney failure. And they deployed it in the NHS in the UK. And essentially what they found was that, they basically gave the predictions to the physicians. But one of the challenges was, even with like a good model, it was really hard to for the clinicians to figure out like what action they would take in order to do something preventative that would help the patients. And so functionally, it became very challenging, and ultimately the deployment actually didn't improve renal outcomes themselves. They didn't improve kidney outcomes. But on top of that, the other piece of this in the deployment segment is that it also created extra burden for the physicians, and then they sort of stopped using it. And it made it very challenging. And so those pieces combined, I think this is like a great experience that they reported to kind of tell us a little bit about like some of the things that we should be thinking about when we're trying to get things into healthcare settings. And we'll talk a little bit about this in the study design of some of our work too. And then this whole thing is also a cyclical process as we're trying to design things appropriately. And then the Decide AI guidelines actually came out within the past couple of years, kind of giving some guidance around like designing clinical trials around AI. I think the sort of too long didn't read version of that is that we should often be thinking about like kind of higher risk AI type models in the same type of lens we think about devices and pharmaceuticals. So as a physician, I often harp on the fact that we need randomized controlled trials because that's a major driver of adoption. And I'll talk a little bit about this in some of our qualitative work. This is an old tweet from Eric Topol pre-COVID. If you guys can imagine that, 5 years ago. And I still use it because the sort of the story there hasn't actually still changed that much. There's this paper over here, which was published just last year, had a list of the randomized controlled trials, or actually just prospective trials, using machine learning or AI in some capacity in oncology. And it is a short list. And so I'll be talking about the study actually at the top, Shield RT, and our experience there. So we still have a lot of work to do in trying to translate things to clinical care. I'll throw a pitch for PCORI, which is the Patient-Centered Outcomes Research Institute. They fund a number of studies. But PCORI actually has a nice resource with like a little evidence map that you can kind of click through to see different algorithms in different healthcare settings. All right, so let's get into the meat of things. We'll talk a little bit about a trial that we ran. So acute care, unplanned acute care, so that's like hospitalizations, ER visits. That's a major concern across like kind of all healthcare domains. Probably about 5 years ago, I guess a little bit more than that. Let's say 7 years ago, that really became highlighted by CMS, and became a priority for cancer centers. It's like involved in a lot of quality metrics, and became increasingly important. From a radiation oncologist, certainly one of the major issues with unplanned ER visits and hospitalizations is it often interrupts radiation treatment. And we know that radiation treatment is designed to be delivered sequentially, and treatment breaks, especially for certain types of cancers, can really impair outcomes. So cancers like head and neck cancer or anal cancer are very sensitive to breaks in treatment. And so, there was a lot of like kind of discussion about, well, how do we try to reduce unplanned acute care, make it easier for health systems to try to mitigate this risk? And so that was kind of the way that that this problem came up. And so, well, I said, well, actually, in the same paper, so I shouldn't take credit for the idea. The one of the concepts was, well, can we do a better job of like finding the high risk people and doing something to mitigate the risk? And so at that time there were a lot of like machine learning papers that were coming out about hospital readmissions and stuff, and I was like, well, let's do that in radiation oncology. So when I was a resident at Duke, we took our experience there, over 8,000 courses that were treated over a 4-year time period. We at the time I approached it as, let's take electronic health record data that is similar to what we teach medical students and residents, what to extract. And so like I thought to myself, well, this is like a thing from like old Mac OS or whatever. I guess OS probably before OS 10, but there's a list that we teach all medical students in like their sort of history and physical skills, of information that like we're trying to gather. And then let's do the same thing, except automatically synthesize that data, and then make predictions. And so the idea was we created a number of different machine learning models at that time. The overall winner ended up being a gradient boosted tree. And then took that, did the whole like validation process as usual, had some ROC curves, published a paper, got excited about that. That was nice. But really the question was, well, can we take this to the next step? Can we try to implement this in a clinical setting and actually put this in the hands of our clinicians? So with that, SHIELD RT was born. You guys in the room, it's like obstructed view from the Zoom thing, but it's actually, the acronym actually makes sense. It's a System for High Intensity Evaluation During Radiation Therapy. I'm a bit of a stickler for my acronyms. So I like there are all these acronyms these days where like the letters actually like in the middle of the word. So I do my best to stick with an actual acronym. But this study we ran as a randomized quality improvement study in our department at Duke. And what we did was we took all adult patients who were being treated for any type of cancer with radiation for a duration over a week. Their data, electronic health record data, plus their treatment, like intended treatment plan up front, were brought into the machine learning model, in this case, the gradient boosted tree. And then basically we took the risk calculation and managed their randomization that way. So those patients who were low risk essentially just got triaged through. And as I mentioned earlier, we see all of our patients one time a week to manage any of their side effects. What I didn't mention earlier is that we also see patients more than once a week when we identify that they're having some problems or struggling with like side effects of radiation. So for instance, for patients with head and neck cancer, as they're going through radiation, like their treatment courses, they're getting into the latter parts of their radiation treatment, they start having trouble like swallowing, that affects their nutrition. And so we try to manage that well. That process though, clinically for physicians is often like fairly reactionary. So it's, well, John Doe is having trouble swallowing, we need to do a better job of like kind of trying to slow that process down. And so the idea was to try to be a little bit more proactive in this study. And so those patients who had a high risk of an acute care visit, which we defined as 10% or greater, they actually got randomized. So half of them were randomized to the standard treatment, and then the other half had a required secondary evaluation by any member of the clinical team. So as I mentioned earlier, cancer care in general is a multidisciplinary sport. In radiation oncology, we also have a number of different team members. And so the folks who could carry out the extra supplemental evaluation could be advanced practice providers, so nurse practitioners or physician assistants. They could be nurse clinicians, they could be residents, they could be MDs, but the idea was to get an extra touch point on these patients. Really randomized control trials, I should say, for kind of the non-clinical audience, like randomized control trials, as you would imagine, are kind of the gold standard in clinical evidence, because it helps us deal with a number of the unmeasured confounders that exist every day in our clinical practice. And so randomization is important, but it's also very resource intensive, very hard process to manage. So actually 963 patients getting screened and 300 randomized patients is actually it's actually a pretty large study. Thinking about some practice changing trials in cancer, a lot of them are smaller.
So the risk scores are obtained from the model
Yes,
that you
yeah,
developed, but
yeah.
like, why are you randomizing the people with high risk, not randomizing the model itself?
Yeah, so that's a great question. I actually don't have it on the slide for study design considerations. But I actually originally designed the trial as a trial that involved randomizing the model or not. What happens is then the number blows up on you really high, because if you randomize up front, you're also sort of randomizing people. Your effect size becomes smaller if you include the low risk patients. And so when you randomize up front, study becomes huge. So I think my original trial design I should say compromises are frequently made in designing clinical trials. A big part of that is that, it's a big commitment for a lot of patients. It's a big commitment of time. I participate in some cooperative groups that design clinical trials nationally. As you can imagine, like a lot of people have different opinions and stuff. And so many of the major trials that you guys will encounter have a lot of compromises baked in. This was one of them. And I can't remember the exact number, but I think it would have taken us probably 4x the number of patients or something like that to get the trial done if it was designed differently. But I had thought about that question, and then sort of kind of changed the slant. So I'll show you guys some of
Do
the
you have like a
data.
rough estimate of the cost of the trial, just to give them a sense of like how expensive it can be?
Oh yeah, so this trial overall was not too bad. Actually, actually talk about cost considerations in a second. So we'll get to that part. But the big part of the cost of this trial was time. For our staff in particular was the main cost. Part of that has to do with how clinics are set up and how payments are bundled, which is a whole conversation around specific care domains. But we'll talk a little bit about the scale. Yeah.
How do you ensure that you're comparing apples to apples and impacts when your inclusion criteria is really broad? Like it's patients with all types of cancer.
Yeah.
They're starting from different baselines.
Yep.
So I imagine the capability they have to improve is different.
Yes, and so that part of the idea is that's what the randomization is for. So the idea is like on each half of the randomization, those patients, all of those random confounders will get randomly distributed through. I think part of your question is probably around effect. So it's if it works in the broader population, does it still work in subgroups? Which is also a separate question. We did some analyses on that too. There are certain disease sites where the management is maybe not as impactful, I guess, as in other disease sites. But actually, and I don't have a slide on this, but and I'll just give you guys a spoiler. So we found that reduce acute care events, but one of the things that I should say is a big part of the management was actually educational. A lot of the elements, the interventions that were carried out at many of those visits were actually you know, kind of talking patients through what's kind of expected during treatment, versus some of the other things that we do. So fluids and pain management are probably the other things like that are more proactive there at the top. But certainly differential effects, you sort of try to tease that out in the subgroups and stuff. And you kind of have to decide. It's a good question about like kind of just generally how do you design trials and how do you want to think about things. And the part of it is like one of the important things, and this is true of when you're designing models, is like you want to think about how you're going to use it later for how you test it. Because if and this comes up in other sort of cancer management clinical trials, but you want to make sure that it is appropriately applicable to the population you want to apply that decision making to later. So there is a history of trials where we set out to answer a question about a specific population, and then the enrollment criteria was a little bit broader. And then the patients who actually ended up being enrolled were maybe not exactly the patients we needed to answer the question in the group we were looking for. And so those are all like important things to be thinking about. And sometimes we do broaden enrollment criteria because of just how many patients, you know, you need. And then that changes a lot of the rate considerations and stuff. So it's a very nuanced question. There are a lot of things we could talk about. So okay, so real quick, just other study design considerations we had when we were putting the study together. So one thing that you know, that I mentioned earlier in the DeepMind experience was that the clinicians were given, you know, sort of an alert process. And we actually had a conversation about this yesterday at one of our American Society for Clinical Oncology meetings. But the idea that I had here on this study was to actually like sort of force and like a direct clinical engagement. So the physician or the clinician could make a decision on what they were going to do for the patient still, but really was to like have that like force the touch point. One of the things that you'll sort of see throughout clinical decision support type studies is that the clinician can decide to ignore the alert and or you know, not believe that it's accurate. We'll talk a little bit more about that too. And so, you know, part of, you know, what I was trying to do was prove that you know, directing the care would actually make a difference. And so once you've sort of, this is a little bit of a cyclical chicken and the egg type thing, but once you sort of need to prove that to improve the buy-in for the physicians later. And so the idea was if we can prove that, then clinicians will be more likely to sort of follow the recommendations later on. The other consideration, I designed this trial when I was a resident, and I wanted to make sure it was minimally imposing on my attending physicians. Part of that was we needed everybody's buy-in to actually deploy it. And in a busy clinic, you know, we just don't have time to like get an alert, have to think about it. We're already multitasking. And the idea was to try to streamline it as much as we could into the process. We'll talk a little bit more about that with staff. And then we got kind of lucky, sort of, I think to Ahmed's point, somewhat related, but one of the things that we were trying to do as we were designing things was the power calculation and what we could actually do in our clinical setting. And, you know, with continuous predictions that are well calibrated, you can sort of change, you know, alter your threshold, which is one of the nice things. But it actually turned out that, you know, I pulled some radiation oncologists and we sort of thought 10% was like a sufficiently high risk to be actionable. And it just turned out that 10% also agreed with like some of the mathematical cutoffs. And then that actually also worked out that 10% ended up being about 30% of patients that came through our clinic. And with half of them being seen for an extra visit, that's like 15%. And we happened to have hired like some extra staff going into the year that would be able to see that sort of extra burden of patients. So like a lot of things kind of lined up for how like practically we were able to implement the study in our clinic. So ROC curve, I think the AUC was like 0.8, it was over 0.8. And then a calibration curve for those patients who were not intervened on from the study. Sorry, I actually wrote down the AUC in my notes, 0.85. But this is what you guys are mostly here to talk about, which is like, you know, kind of the outcomes on the study. And so I sort of, in our decision-making process where, I knew that we weren't going to be able to feasibly do a randomization up front with the extra patients. I sort of said, well, for the low-risk patients, is it acceptable that they didn't get an intervention, essentially? And so those low-risk patients had a less than 3% risk of an acute care visit, pretty darn low. And then if you look at so I think that was kind of how we ended up evaluating that piece of things. And then those patients with at high risk without being intervened on had a 22% risk, and we were able to cut that in close to half down to 12.3%. So that was kind of the main take home, but we've since done a few other studies, one of which was a cost analysis, which I think is important, especially in the considerations of hospital systems, insurance and payers, really trying to have some cost reduction. So we actually published a study just a couple of months ago in New England Journal AI, showing that we were able to reduce costs. And the way that we approached this was to look at short-term financial benefits. The main reason for that being that, reducing hospitalizations and ER visits would likely be a short-term impact. Cancer is a longer-term disease, but if we can try to reduce, those healthcare touch points, it would be advantageous. The cost analysis was done from the health system perspective. The reason for that is radiation oncology payments are bundled. So if a patient comes in for radiation treatment, the insurance payers sort of pay for that radiation course, but the hospital system actually sort of takes the cost of the things that sort of happen during that radiation course and like the support that we're giving on an outpatient basis, things like that. So those things get bundled together. And then we basically took our payment system and looked at various types of costs. So the primary endpoint was total cost, and I can catch that one later. Total costs. We also looked at variable costs, which sort of change based on the patient. And then CMS does have a designation for preventable visits. So we tried to see if those costs were disproportionately reduced. And then we also did adjustment for patient and treatment factors. But the main take home is across all of those adjustments and all of those domains, we're able to reduce costs per radiation course. So essentially there was a roughly $4,500 kind of increase or cost of acute care that's tied on average to a radiation course. And we were able to cut that sort of excess cost down in half for those patients who were getting the intervention. And that same kind of magnitude difference was seen across the different cost domains. I didn't include this in the slides, but we actually kind of broke down like the different visits. And I apologize that I don't remember the number for how much the intervention cost off the top of my head. It's in the paper. It's in like table 1, maybe table 2. But we did kind of go through like, ER visits, ICU visits, hospitalizations, all of the outpatient tests, any outpatient supportive care, like urgent care visits, things like that. And there was actually not a predominant theme for where the costs were being saved. It was actually just kind of across the board. So if you break it down a ton, it ends up being kind of smaller costs that are distributed across a number of different domains. And again, as I mentioned earlier, like a lot of the intervention was actually education based. So there's a lot of like trying to support patients through the treatments that they're going through. And that's like an important kind of theme to think about. So we've been working on some more qualitative data and qualitative analyses, kind of post hoc. This is actually a survey that we sent out before the study results were reported. As I mentioned earlier, we sort of polled a very diverse body of staff. So the physicians, the attending physicians were on this, the residents were on this, advanced practice providers, the nurses were on this, and then our radiation therapists who are actually trained to deliver radiation were on this as well. And essentially, the core of folks felt that it did not disrupt their workflow. The people who were most affected were the people carrying out the extra intervention. So that was our advanced practice providers, and then some of the therapists, radiation therapists as well. The second piece was, I pulled them all just to see how much they agreed with the machine learning prediction. And it's a sort of a theme throughout kind of clinical predictions, that, physicians certainly are more optimistic than sort of the ground truth. We've seen that across a number of different studies. The interesting thing we found here was actually that the clinician predictions were pretty poorly calibrated. And I'm sorry for everybody who's in the room that the Zoom thing's in the way, but basically you see those big confidence bars that are there, and the predictions were kind of all over the place. One thing I did notice was a lot of folks that you can see the large bar around the 0% clinician predicted risk. So there was this feeling for a number of folks that like patients would not be, would be highly unlikely or never, I guess, have a ER visit or hospitalization during the course. And you can see how kind of broad that ended up being in the confidence interval.
So how much of the role of machine learning here is like finding through clinical risk factors that people are overlooking versus just being like a persuasion tool?
Yeah, I mean,
you
I
could
think-
actually be more pessimistic about this.
Yeah, I mean, I think that I think what your latter is right, which is basically to recalibrate yourself
Yeah.
to help us calibrate the right thing. Because I think the risk factors, and I didn't include this in the slides, but when you go into the model, the risk factors for the most part are not terribly surprising. They overall pretty much make sense. Some of it is just synthesizing that data to come up with something objective. But I think to your point, like a lot of this is true, I think, of a number of different models, which is like one, to formalize, the relationships between the predictors, but two, resync us to the right spot. And I think again, we tend to be overly optimistic more broadly. So and then we're trying to actually do a deeper dive into this. So Farnham, who's actually a student over at Haas here, she is also an MD, is doing interviews with our team that participated, both did and did not participate in SHIELD, to understand qualitatively, both their thought process and engagement with the system, but also how it changed their perception of AI and machine learning, and how that can like drive adoption essentially. All right, so I want to leave you guys enough time for questions, so I'm gonna kind of blast through the end of this. So we're coming up on the end. So all right, so we wrote a paper about implementation too, and kind of the considerations in our clinical workflow. I've highlighted a few of those, but really the system worked as, we calculate the risk, we send an alert, that alert goes to the team that's doing the treatments, the patient gets treated, and then those folks who are high risk get funneled over to see their team during a visit. So a couple of things we figured out. One, commercial health information technology systems are cumbersome. It's hard to be nimble in an academic health system. That, I think that certainly makes sense. And so there's a lot of like building out custom tools and custom environments to try to make this work. We are actually actively working on some things that are more embedded into the Epic system. But to really move quickly, I think it takes a little. One of my colleagues from the University of Pennsylvania described this as MacGyvering, which is, when he said that, I was like, yeah, it's pretty much like the experience that I had. And then the other part was the clinical workflow. And I mentioned earlier that there was a subset of folks who felt like this was more disruptive. And probably the biggest thing in the staff and physician and patient experience was just patients, we totally changed the workflow for patients who are high risk. They had an extra visit. It wasn't necessarily consistently on the same day every week. And so there was a lot of like ad hoc changes. And so it could be confusing for patients, confusing for staff, just to get people to the right place. So this has nothing to do with the tech. It's just about how we interrupted the clinical, environment. I will say the vast majority of the visits actually got completed, but it required some extra effort on our side to make sure that that actually happened. And then explainability. So I think I don't know if people recognize where the screenshot's from, but Harold and Kumar, but this study got done in an era where a lot of people were asking, like, are physicians comfortable adopting black box models? I probably read like a gazillion papers about that. But at the time, there actually wasn't that much discussion about what do patients think. The patients are very, very curious, and one of the, things that we got out of this experience was that we had a number of patients ask, like, well, why was I high risk? Like, how does the model work? And genuinely just kind of curious about like how the workflow worked. And I think since then we've learned a lot of lessons about patients being interested in like, how are the models considered? Are they driving my care? Is my physician still kind of running the care? How does this input happen? And so actually since this study, we have actually been engaging with both with patients and patient advocacy groups to really kind of understand a little bit more about their perspective. And that's actually very, very very diverse opinions, certainly like geographically diverse, but you can imagine a number of different kind of factors that work into this. All right, so we are working on some things I think important to talk about, but machine learning models can break down over time. Jean Feng is also a CPH member and a talented biostatistician / computer scientist interested in how we surveil machine learning models over time. So her interest is specifically in auditing, understanding how data changes, which breaks models. We're also interested in things like automation bias and fairness, but all things that we can think about because we've got kind of a longitudinal experience. And we do have a grant from PCORI to work on that. And then people who know me know that I tend to be a little bit cynical about generalizability, especially for problems like this. Healthcare itself is very local. And so I think I read a quote from A.B. Abernethy recently, who's at Google Health and the FDA before, that, one of the key questions is like, does this work for this patient in my local setting? As opposed to something broader. And we've seen it a number of times where, models don't generalize well. In either case, we're still working on some generalizability studies. Probably for me, the main thing is understanding where do models break down because of different demographic and resource factors or operational factors. So we have a nice kind of collaborative national group with both community and academic centers. I'll give a shout out to Mari, who's on this slide. I think she's logged on, but she's one of our CPH students. So it's a great team to work with. And then I'll talk just kind of briefly about some of the other work we're doing specifically on wearable devices. We actually have a model that was published a couple of months ago, basically taking 2 weeks worth of step count data to make predictions of unplanned hospitalizations. The wearable device data is actually from one of my collaborators at Montefiore in the Bronx. And he's got some of the sort of leading experience in collecting wearable device data for patients who are getting chemotherapy and radiation. And we're taking this model and validating it on a national trial that's running by NRG Oncology, which is a cooperative group. The premise of this study is basically to take patients who are getting chemotherapy and radiation for lung cancer and randomize them to with or without a wearable device, and then validating the model. And then here closer to home, we actually have a study that I think is going to open next month. The primary endpoint is to validate our existing model, but secondarily also validate the SHIELD model, but we'll also be collecting other exploratory wearables data to help us see if we can find, other type pieces of information that can do a better job of making predictions. And then part of it is that we're using Fitbits. The original data was run off of a Garmin device, and then patients can actually, who are participating, can actually also volunteer their Apple data. So then we can try to look at like it's inter-device agreements and whether things break down. And with that, I'll just say I'll wind things down, but we do have the ability to integrate AI in clinic. It can be challenging, but I think having multidisciplinary collaborations are really important, and trying to bring things together. It really does take a big team, and we still have a lot of questions that we have to answer still. So with that, a big shout out to folks we've worked with, and I will leave my contact information. And I think we have 7, is that 11?
Yeah.
So we got 7 minutes for questions.
Thanks. So yeah, we can take questions from the room, but if you have questions, if you're attending virtually and have questions, drop them in the Q&A and I'll read them out loud.
How does the model predictions from the SHIELD RT get shown to the clinicians? Like, is it a black box for them too, or?
Yeah,
Do
so
they see?
that's a good question. So
That's-
the way that we ran the original trial, was it actually was purely a black box. They could have it on request. But it was, so part of it, I mentioned earlier, we intentionally tried to make it easier for the physicians and reduce their cognitive burden. So actually, we had a number of physicians tell us that they actually didn't want to know the predictions. They just wanted like the process to work without them having to think about it. The way that it worked was, patients got randomized and we actually just put everything through the work queue. So the physicians, they get informed, and their team talks about it. But unless they actually, I don't think we had any physicians request a prediction. They, they could have it if they wanted it, but you know, I think everything kind of just went through, so. It's a good question.
You mentioned for Shield RT some of the interventions or education. Can you
Yes.
explain the mechanism on how that works?
Yeah. I mean, I think there's a couple of pieces around it. The education piece, I think, is a big one, probably like mostly in the setting of trying to reduce ER visits. I think part of it is telling folks that something is not, you know, is expected and not something that is sort of really like needs like emergent care. So I think a lot of it is like some of that sort of reassurance and teaching process. There are also other parts I think that, you know, we'd include in education. So things like, you know, a patient has a specific like medication regimen already they can use, and trying to talk them through how to use it and manage it, you know, at home, is also, I think, another piece of that. Yeah, I think like we found like a number of the visits were really just like really just touch points. And then as I mentioned earlier, I think after that, this is actually in the original paper. I'm just trying to remember off the top of my head. But after that, I'd say fluids was number 2, I think. And then pain management was number 3.
To kind of add on to that, do you know like the distribution of how much of it was awareness, like what you discussed?
Yes, right.
And how much of it was like a behavioral modification? So they were educated to change the way they
Yeah,
behave,
that's a good
to
question.
take care of themselves
Yeah,
better.
that's an excellent question. I actually, I will be totally honest about it. I actually have no idea. I will say this is purely anecdotal and from having read, you know, because I did read through the like notes, the documentation of the visits. And I'd say anecdotally, I think they're mostly the former versus a behavioral modification. So, yeah.
Interesting.
I might have missed this. So you mentioned cost savings. I'm
Yes.
wondering if that was from the health system perspective or whether or not you also took into account patient costs, like the cost of having these additional touch points,
Yeah,
like
yeah.
getting to the hospital and like having to budget that out of their day.
Yeah, so
essentially.
we actually didn't account for the patient directed costs. So this was purely from the health system. Yeah, I think a lot of important considerations like travel time, folks having to be in the hospital, having to come in for like extra visits in the commute time, all important things. One thing I'll mention is, you know, radiation is just kind of a unique thing in the aspect that like patients come in like every single day. And I didn't touch on this earlier, but it goes into the questions about the interventional strategies. Patients come and ask me about like kind of every healthcare thing that's coming up during their treatment, even if it's not like necessarily directly related to their treatment. And I sort of consider them under kind of our watch. Many of them are in town, for instance, away from home, away from the rest of their healthcare team. And so I'm like, you know, I think the radiation oncologist is kind of the main point person to manage a number of different like health concerns and stuff. And it does like, you know, if you look at some of the events, the types of events, which we broke down as well in the paper, if you guys are interested, they're across like all sorts of stuff. Like the domains are, you know, are very fragmented. One thing I'll just throw in here, just because we've been talking about the intervention, one thing that I did think about, which fortunately the effect size was pretty clear, but one thing I did think about that I was a little bit worried about was whether or not there was a separate interaction between the extra visits and acute care rates. So for example, if like, you know, because we will tell patients that they need to go to the ER. if something serious is happening. And so then the question I had was, well, are we going to end up sending more people to the ER because we're doing the intervention, which I don't think was like, it was not a given that that wouldn't happen when we set out on this study, but that was one thing that I was a little bit conscientious about going in. Can we get the Zoom question?
Well, we can take the Zoom question, because then.
Yeah, I think, yeah, so there, there's a Zoom question that's about, intention to treat versus per protocol. Um, so, and then a question about blinding. The analysis itself, was actually done. I'm trying to, so the number of, patients who didn't actually have their visit done was super, super low. Like, I think it was less than 5, if even. So we did do a separate, the study was done as intention to treat. But the sort of per protocol number was basically the same. And I think we did the analysis also on the back end, but because it was very, it's basically the same patients, the difference was pretty limited. And then the other question was about blinding to assess the outcomes. Also a great question. So she caught me on that one. So one of the things that we did, I showed you guys the figure of the calibration for clinician predictions. But because we didn't want to harass the clinical staff to give us predictions on every patient, because that's like one way you could run the study, right? Is have all the clinicians make a prediction for every patient, which is a lot more cognitive burden, not something we standardly do in the clinic. People ask that question, it's like physician versus machine learning, but the problem is that the physician prediction is not costless. It does have a huge cost on the cognitive burden. And so what we ended up doing was just asking the clinicians for the patients who were intervened on. And so there's actually a little bit, I don't know if anyone noticed that, there's a little bit of anchoring around the 10%, which I don't think is coincidental. Because people making the prediction they were not blinded to the fact that they were at least high risk. So they knew going into it that the model had predicted they were more than 10%. That said, a lot of people still said 0%, even with that in mind. So, but I did notice a lot of clustering around 10% predictions.
Other question in the back.
I was wondering if you talked a bit about the problems with generalizations.
Yes.
I remember we attached to that also, having thought about like the scalability of using AI models like this in maybe some health systems or the world systems. But also in those staff, and they're it's one thing to do this at like staff.
Yes. Yep.
And have these larger resources, but.
Absolutely a wonderful question. So for anyone on Zoom that couldn't hear the question was about not just generalizability, but from kind of a practical perspective, like being able to generalize this practice and this system in a smaller healthcare setting with less resources. Which is, I think, a wonderful question and part of kind of our vision study, because we do intentionally have a couple of community sites participating. I do think that that's like one of the main questions that is being asked. Just to give you an example, like for our wearable study, that was a question that they asked, which was like, can you guys prove that you can do this in a smaller setting? And the NCI and a number of funding agencies are prioritizing that element. It is hard. So, I think, and this is one thing, is like, we're able to create all these like little like kind of localized bespoke models in like our larger healthcare system, but to like actually figure out how to do the whole thing and then like throw in the auditing thing into a smaller healthcare system is very demanding. I don't think we have a great answer for that yet, to be totally honest. Because again, local clinical environments, I do believe matter. And I think it's something we need to figure out. I think part of our study, like we're trying to figure out some of those elements as we go through like everybody's IT systems and understand like, can we get this to, operationalize? And then like, I think on top of that, it's like, with this intervention, you have the clinical staff to carry out the intervention. It's part of the discussion in the paper is like, well, if you have less resources, you can't see as many patients, you just take a higher risk threshold. But I think that makes it sound more trivial than it actually is. And I think, that is an important, for those of you guys who are thinking about like, you know, products and things like that, like that is a key piece of all of this, is to figure out, you know, because the vast majority of patients do get treated in the community. And being able to scale these things in settings that are under resourced or less resourced, this is really important.
I have a quick question about deployment.
Yeah.
So you said that you're kind of building a model to embed into the Epic.
Yes,
I know
yeah.
that oftentimes it's kind of limited in terms
Yes.
of what you can actually do with Epic.
Yes.
So I also don't know how many features you originally had in the original model. So do you think the model performance will hold up after you actually deploy it in Epic?
Yeah, so we're actually, the model we're deploying in Epic's a different model.
Okay.
Travis Zach, also CPH faculty?
Yeah.
Travis Zach, who was a former fellow in my lab, I skipped the slide at the end because I was running out of time. But Travis, and Travis led, one of the AI deployment projects at UCSF. We funded a couple of them. I just kind of rode his coattails. And part of it has been trying to get, a couple of his models, around chemotherapy side effects into Epic. He actually hasn't had to make any compromises on the model data. It's all back-ended on Clarity, and I think he hasn't told me that there have been any issues on the back end. I think the interfacing part is limiting, which is like, how can you visualize and present information to a clinician is all like constrained by the Epic system itself. So that's been the main like limitation for us there.
We will have some speakers in the future from UCSF who work more in the IT infrastructure and deployment.
Yeah, we have a great
the more
team.
engineering
Yeah, we
aspects
have a
of
great
that.
team over there. So there.
So let's take one final question. I know you need to see patients. Let's take one final question from the chat from Alice Dang.
All right, so Alice's question is, what do you think about ensuring that we think about building models for other healthcare team members beyond clinicians? And then she had something nice to say about mentioning the interdisciplinary team in our talk. Absolutely, I think there are, it's very like, so healthcare is intrinsically very, very multidisciplinary. And, you know, to a certain extent, like this model was really focused on, you know, actions that were carried out by very specific staff, and actually mostly non-inclusive of like the physicians themselves. And so I think having predictive models that can, I think, consciously work into helping us in like other specific decisional settings, whether it's, you know, there's my radiation oncology world, but like if you think about like, you know, like all of the other sort of technologists throughout the hospital, all of the other like staff, especially like nursing staff on hospital floors, there are a lot of places, so to speak, there are a lot of pieces of healthcare that we can optimize a little better. So certainly I think being conscious about different problems and the nature of different problems is really important.
Let's thank our speaker again.
Yeah, thanks for coming, guys. I don't have to rush out, so if anyone wants to talk real quick,
Oh, that's
that'd be
great.
okay. I think my patient's on till like 12:30, so I have a little bit of time. So, all right, thanks, guys. Thanks, Zoom
Okay.
people.
Thanks, everyone.